Stop smiling.
Oh, I'm smiling because I could not see you. Okay, we are live.
So good evening, everyone. I welcome all of you to this session of Fertility Masterclass number 77, which we will be talking about stimulation protocols in lean PCOS in natural conception. And I think this is one of the most challenging situation which any of the general gynecologists or even fertility experts will come across, where it is harder to treat a lean PCOS than a obese PCOS is what my experience has been, and how different these two phenotypes are, and what would be the management protocol in lean PCOS is what this class is about today. So over to you, sir. You can take over.
Yeah. See, I will share screen. Can you can you just see if the screen is shared?
Yeah, it is.
So this class is going to be discussing stimulation protocols for thin PCOS or lean PCOS. Okay, who want natural or IUI conception. Okay, so otherwise, this is a very straightforward class. All right, there are certain important things which we need to understand in this class. When you try to talk of thin PCOS and the ovarian appearance is of multifollicles, okay, whenever you are having a multifollicular appearance in thin PCOS, remember the classical problem is going to be excessive androgen, and the classical problem is going to be excessive LH. Okay. Of course, there will be impaired insulin resistance, but along with all these things, the most important thing in thin PCOS is excessive androgen. Okay. So what typically goes wrong is that if you look at the microenvironment of this follicle, if I just enlarge this follicle, then in the microenvironment, the androgen is much more than the estrogen. Okay. Now, because the androgen is much more than the estrogen, what typically happens is majority of these follicles will undergo apoptosis, and as a result of which, quite a lot of will be empty. Or because of a high androgen microenvironment, one thing will happen is that they will have poor oocyte quality. All right. So the most important thing which you should understand when you are stimulating a thin PCOS patient is that it is not just stimulation which is important. It is stimulation to result in a good oocyte. Okay, which is very very important in these patients. Otherwise, what will happen is if you just give a standard dose of letrozole, let's say, and you will say, I don't want OHSS, so I'm giving extended letrozole, let's say 001 for around 7 to 8 days. Okay, I saw that out of the four follicles, one follicle became the dominant follicle because I had given estrogen. I mean, because I had given letrozole, estrogen was less. Let's say it was 50. I gave HCG 10,000 trigger, and after giving HCG 10,000 trigger, it went into luteinized unruptured follicle syndrome. Or I tried it for 3 to 5 cycles. That's the second scenario, and there was no pregnancy. Okay, so here the problem is not your stimulation. Actually, the stimulation with letrozole which you did was right. The problem is you did not optimize it enough to get a good oocyte. Okay. Obviously, friends, the other prerequisites for this is going to be same. You need to have patent fallopian tubes. Okay. Mandatory requirement. That is one. In these type of patients, along with patent fallopian tubes, you also need to ensure that the husband semen analysis factors are absolutely normal. If they are not normal, forget a pregnancy. Okay. Along with all these things, the results are going to be the best if the AMH value is less than 9. Okay. Usually for AMH values more than 9, what really happens is that there is a very poor quality oocyte. Okay. It's a very poor oocyte quality. So you must keep that in mind. Okay. With this much basic knowledge, when you want to stimulate a patient for thin PCOS and when you want to actually attempt something, okay, what are the things which you need to keep in mind by understanding this physiology? Okay. So, no point wasting time going into any theory. Let us just go by the protocol and how should we memorize it to give the best outcomes to our patient. Okay, so obviously every patient is a thin PCOS, and our treatment is divided into two, either natural or IUI. These are the two broad categories which we are going to look at, and then there are going to be several points. Okay, let us look at the role of pre-treatments. Okay, so in the pre-treatments, let us look at oral contraceptive pills, and let us look at GnRH antagonist. Okay, that is one. The second, which is important, is stimulation protocol. Okay, third, which is important, is trigger. Fourth, which is important, is luteal phase support. Fifth, which is important, is adjuvants. And in adjuvants, let us look at steroids, let us look at inositol, and let us look at metformin. Okay, so these are the criteria on which we should try to divide our answers. So the answers are very simple. Oral contraceptive pills are extremely good to reduce androgen, and they are both extremely good to reduce the LH values also. But it is ideal to give these tablets for at least 3 to 4 months in these patients as pre-treatment. Should you think, okay, that the patient is having an androgen excess, which is commonly going to be diagnosed by hirsutism. Okay, GnRH antagonist pre-treatment, even if you have given OCPs, I think GnRH antagonist pre-treatment is something which is magical in these patients. Pre-treatment to be given for 2 days, even if they are trying naturally. Okay, in both the situations. Obviously, guys, I want to remind you that when you have a natural intercourse protocol, you want 1 to 2 follicles. In IU 1, 2 to 3. Stimulation protocol is an absolutely standardized stimulation protocol. Letrozole 2.5 plus HMG HP 150 international units. No changes. Both are to be given for 7 days. Okay. Both are to be started from day 2 and day 3 of the menstrual cycle. Your primary ultrasound will come on day 8 or day 9. And your trigger is a standardized trigger. No need to use your head. The answer is 10,000 FTG. We have discussed this in our previous class. Luteal phase support, answer is very simple. You need to give luteal phase support. So it is going to be progesterone gel. 8% can be given twice. Okay. Role of steroids, limited. I would just say it has no role. Role of inositol. Which you like more? You like D-Cairo more or you like myo-inositol more? People can answer in the comment box, because whatever you like, both these guys are absolutely fantastic, as both of them have got no role. All right. Role of all your beautiful tablets: OVA Bless, OVA Bliss, OVA Care, OVA Fair, OVA M, OVA T. What is that? Fertisure F, Fertisure M. Everybody is in this category of no role. Okay, because they are simply multivitamins. They may or may not exhibit any role. Metformin. It is one answer, and that is beneficial, and it is to be used when there is an abnormal GTT. Okay, that means on 75 gram GTT, only one value is supposed to be abnormal. In that situation, please use metformin. Okay, fine. When I mention about the stimulation protocol, can I go from this letrozole protocol to an extended letrozole protocol? So we know that extended letrozole protocol is a great protocol. So I wanted to include that. And the answer to that is yes, you can do that, but it is good for natural intercourse. I don't prefer it so much for IUI. Okay. Finally, after all this discussion, if you remember this flow chart and do not spoil your head with anything else, okay, you know that in thin patients, there are two other important things which are important. Okay. So I will come to that. They are not controversial, but I will come to that. All right. So that everybody should follow. Okay. So the first thing it is important is role of laparoscopic ovarian drilling in thin PCOS patients. Okay, just remember one thing, guys. Role of laparoscopic ovarian drilling, it exists if more than 2 to 3 cycles show no response. Okay, despite using this protocol, if 2 to 3 cycles show no response, that is one. One, I'm also going to mention about an experimental therapy called transvaginal ovarian drilling. Forget laparoscopic ovarian drilling. This transvaginal ovarian drilling is absolutely fantastic. Okay, I have now done more than 100 cases of TVOD. So we have excellent record of this. It is a completely experimental procedure. It will work in thin PCOS patients fantastically well. You should do a TVOD, and immediately after TVOD, you should give GnRH antagonist for 2 days. Okay, and then you should start your stimulation, which is letrozole plus 150 international units of HPHMG, and see the miraculous results. Okay, it's a fantastic thing if you want to try. Okay, so with this and with this much data, which people should keep in mind as far as natural cycle intercourse for these patients is concerned, uh, we conclude the class, and I will answer 2 or 3 questions from Shilpa madam on this.
So how many cycles of ovulation induction with documented ovulation you do before moving on to IVF in these cases?
4 to 6, not more than that.
4 to 6, no? And these patients are more prone for developing OHSS than the obese patients.
True.
So what has your experience been with regard to to maybe prophylactical any medications you give to avoid
We
OHSS?
don't give cabergoline, we don't give anything, madam.
Okay. And so do you do this LH levels on day 2 in these cases just to
No,
check
no, no.
LH
No,
level?
no, no. No, no. Just give, I told you, we have standardized it. Just give pre-treatment antagonist. Irrespective of the LH level, you give pre-treatment antagonist. LH level will go down 100%. The basal LH will go down in 2 shots, and you start your stimulation.
So what is the role of urinary FSH than HMG that you have mentioned along with letrozole? Have you ever
No
used
role. It has
you
got no role.
and do you think lifestyle modification help in these lean PCOS? Because obese so definitely we
Bodybuilding
tell
will help.
them to.
See, any PCOS patient, no, bodybuilding will help. Why I'm saying bodybuilding is because if you build muscle, muscle is able to ensure that the insulin resistance goes down. See, you can't really do any lifestyle modification to change LH excess. It's a brain control thing. You can't do any modification to reduce your androgen. You can't do it. Whatever you are doing is, laser treatment of the hair is to look at the terminal effects of the androgen excess. You can't really control it in any other manner. The only thing you can do is bodybuilding. That is why even if when patients with this obese PCOS, we tell them you do cardio, but you do strength training. Why are we asking them to do strength training? Because we want the muscle mass to go up. If the muscle mass goes up, then insulin sensitization goes up. And if insulin sensitization goes up, the chain of PCOS can be broken down.
Yeah, I agree with that point. So you said about androgen excess. So do you take only hirsutism as a factor for androgen excess, or
No,
is
no.
this
We can also take testosterone level, madam. But the problem with testosterone level is we are ideally supposed to look at free testosterone. Okay, not at the total testosterone. That is why I did not mention it, because otherwise people would write down to do free testosterone, and the values for free testosterone are very erroneous. The other biggest problem about free testosterone is it is free only in the name. The test is actually very expensive. Okay, to do free testosterone, you have to do testosterone, and you are supposed to look at SHBG levels and then subtract it. If you ask a pathologist to do it, he will not even take a CBC sample from your hospital next time. Okay, he will tell you, you do what you want to do. I don't want to do such type of test only.
Yeah, agreed. So when do you cancel the cycle? What are your criteria to cancel cycles? Because we don't want them to
The
end up.
biggest problem in thin PCOS is lack of response to stimulation. That is because the AMH values are going to be very high. Okay, because the AMH values are going to be high and there is going to be lack of stimulation, I mentioned there are 2 procedures. One is laparoscopic ovarian drilling if more than 2 or 3 cycles have been cancelled. And second is if you don't want to do it, see, we don't do it. Okay, we have replaced it with transvaginal ovarian drilling. It is superb. Okay, I was going to post a video of transvaginal ovarian drilling once, and that time you had told me and scolded me, what you are posting nonsense like that. So now I will post again tomorrow or day after tomorrow, and it is a superb procedure. The problem is majority of the people, because it is experimental, they go and drill the ovary as if they are doing egg pickup. Okay, Some nurses will start saying coming, drop from that also. But nothing will come from there. Understand me? Because it is absolutely thick ovary. That stroma is thick. What you are doing in transvaginal or laparoscopic ovarian drilling is you are actually giving a cortical injury. So when you give cortical or a subcortical injury to any of the ovarian tissue, I personally think what it does in TVOD is it increases that cytokines and parakines. And some of those oocytes which are close to the cortex there, they will become slightly more responsive to stimulation. Okay. And that is how it helps.
Okay, what in OCPs, what is your choice of OCPs if you're giving it for 3 to 4?
Anybody who is having a fourth generation progesterone. Okay. Anybody with a fourth generation progesterone which has an anti-androgenic effect. So for example, drospirenone has an anti-androgenic effect. Then that cypoterone acetate, no, Diane, Crimson, Diana, Fina, Tina, whatever. Everybody who has 35 has that anti-androgenic effect. That is good. Okay. Don't prescribe oral contraceptive pills which are having, which are not having an anti-androgenic effect. That will not help you. You know, that will actually help in reducing SHBG. So that will help in reducing LH levels. But that will not help you in reducing testosterone levels. You need testosterone values to go down. So it is better to give anti-androgenic one.
Okay, so in the same context, what is your criteria to start the OCPIL? I mean, do you start it blanket for every lean PCO before
No. I don't.
Or you
I'll tell
do?
you.
Yeah, tell.
No, I'll tell you. The best patient to start oral contraceptive pills in thin PCOS is the one who does not get menses.
Yeah.
Okay. The one with thin PCOS who is getting menses, even if it is irregular, but if she is getting menses, that is a great patient for you. You know, the big problem with thin PCOS patient is they don't get menses because of androgen excess. Okay. Androgen causes endometrial stroma, endometrial thickness basically to atrophy. As a result of which, when you give oral contraceptive pills, you will see that on oral contraceptive pills also they have a good endometrium. Okay. If you select those patients for natural cycle intercourse or IUI or something, they will have fantastic outcomes.
Yeah. So among the symptoms of, say, like acne and hirsutism or acanthosis may not be very commonly seen in lean PCOS, I suppose. I have not seen many. I see them more in obese. So which is that one symptom which is more, what do you say, poor prognosticator, as in like...
Hirsutism.
So I think this is important because the androgen excess is that one factor which will determine the quality of the oocyte. So do you do anything differently apart from giving the anti-testosterone, that is the cyproterone and all that in these cases? Is there anything else? Like, do you advocate steroids in these patients who have severe
No.
hirsutism?
I told you, madam, steroids has no role. You can give flutamide if you want to give, but I don't think results of flutamide are so good because again, flutamide is something which is acting on the end aspect. Okay, so the lifestyle change which you need to do for this thing also does not work so much. Flutamide also does not work so much. Basically, you will just have to overcome it with good stimulation.
Yeah. So, if this thin PCOS, like, I mean, if because of their lifestyle pattern, suddenly they become obese PCOS. Okay. So, have you seen it happening?
No.
These
How
girls,
can somebody suddenly gain 20 kgs weight, madam?
you don't know girls because you haven't met many. You'll be busy, So you should see. I mean, they really put on 20 kilos in 1 year. So today only I saw one patient putting on 29 kilos in like 18 months. So gross PCO. It's okay. So
Ask her to walk from Bangalore to Bombay. 10 kg she'll lose there only.
Yeah, sure. Rather than she walking, I suppose you walking is more possible than she walking. Um, okay, tell me this, like among the symptoms of, as we discussed, anovulation and getting periods only on withdrawal progesterone. Okay.
Yeah.
So I think this is one of the most important factor. Like even if they get natural cycles in 45 days to 60 days, I think they are better off than a patient who gets only withdrawal bleeds.
Yeah, yeah, I told you, right? The most important thing is patient who is getting menses has the best prognosis, madam, in thin PCOS.
Mm-hmm. So do you want to talk about lap ovarian drilling? I know you have replaced it with TVOD, but do you use monopolar current and do you do those 4 pricks
I
for 30
I
days?
humbly request everybody who does laparoscopic ovarian drilling to switch to transvaginal ovarian drilling. Okay. No electrocoagulation is required. No anesthetic is required. Only patient is required. Okay. Nothing else is required in order to do transvaginal ovarian drilling, and it will almost give the same effect like laparoscopic ovarian drilling. It's okay if you don't want to believe me. Anybody who is going to X-ray is going to send a message to me. Arey, what you told 3 months before is right, because even X-ray is now published that transvaginal ovarian drilling is equivalent to laparoscopic ovarian drilling.
Sure. I think I'm done with the questions. I think this was a very good practical session for everyone. So yeah. So AMH is again another factor which we need to consider when we are stimulating, right?
100%. I told that AMH has to be less than 9 to have a good outcome. AMH more than 9 is usually indicator of a poor egg quality, madam.
Kiran sir is asking antag when to give if first cycle fails and patient starts menses or only to be given in the first cycle.
No, no. And pre-treatment antagonist is to be given in every cycle.
Yeah. Okay.
It
Yeah,
is the
sure.
best way to get LH values down. Okay. So it has to be given in every cycle.
Yeah. Do you think the prolactin levels vary too much in lean PCOS or in obese PCOS?
No, no. Actually, prolactin levels in these guys is going to be variable depending upon the secretion of LH which is happening, because all those nucleuses are very close to each other. Okay, so if LH goes haywire, little bit of prolactin, little bit of TSH, all these people will be little haywire.
Mm-hmm. Yeah. Okay. Yeah, thank you so much. I think it was a wonderful session. Thanks.